I'm Bruno Paiva from the University of Navarra in Pamplona, Spain. At ASH, we are presenting an abstract entitled "The Machine Learning Model Based on Tumor and Immune Biomarkers to Predict Undetectable MRD in Transplant-Eligible Myeloma." Why these analyses and the abstract? The reason is the fact that there is expectation of using biomarkers to personalize treatment in myeloma. Yet, a successful treatment selection cannot be confirmed before 5, 7, 10, 12 years of progression-free survival. Therefore, treatment individualization based on the probability of an individual patient to achieve undetectable MRD with a singular regimen could represent a new model towards personalized treatment with fast assessment of its success. You choose treatment based on the probability of achieving MRD, and you confirm if the selection was accurate 6, 9, 12 months after, while assessing patients' MRD status. And with this aim, we developed a machine learning model to predict undetectable MRD in newly diagnosed transplant-eligible myeloma treated with standard of care. And I should say that this is not in the abstract, but hopefully will be in the publication coming soon, that we also validated the machine learning model in transplant-ineligible newly diagnosed myeloma. Well, we started by showing that current risk stratification models, ISS, revised ISS, cannot predict patient MRD outcomes. The only two parameters that are routinely assessed in a patient with newly diagnosed myeloma that are to some extent associated with MRD outcomes are LDH levels and 17p deletion. And everyone knows that while these may be informative, they are present in a small percentage of patients, and therefore they will be non-informative to the vast majority of myelomas. Well, by starting with 37 clinical and biological parameters evaluated, we achieved the most effective model to predict MRD outcomes with the integration of cytogenetic biomarkers, T414 and 17p deletion, tumor burden biomarkers, plasma cell clonality in the marrow by flow, and CTCs in peripheral blood using NGF, and 6 immune-related biomarkers that can also be assessed using the same combination of antibodies that we are using by flow to assess plasma cell clonality. So no additional effort, no additional cost. Of note, immune biomarkers displayed the highest coefficient weights and were determinant to predict patients' MRD status in the model. Now, we demonstrated that the model could predict in 70% of the patients what would be the patient MRD outcome after either VRD induction and consolidation or KRD induction and consolidation. And we also showed that, and this would be to some extent expected, that the model not only predicted what would be the patient MRD outcome, but also was very effective, in fact superior to current models to predict PFS and OS. Therefore, in conclusion, we demonstrated that it is possible to predict patient MRD status with significant accuracy using an integrative, weighted model based on machine learning algorithms. Although immune biomarkers are not commonly used, the raw data from which these can be developed is generally obtained in diagnostic laboratories using flow cytometry to screen for plasma cell clonality. Therefore, we believe that this can be used and applicably worldwide. And to facilitate its utility, we made the model available in the webpage mrdpredictor.com.